the function becomes very difficult. So we need to preserve the length of the fingers for that matter. Just give you one brief moment, please. There is an important call. I'll just. And then maximize the range of movement, obviously, because stiff hand is of no use, especially if there are contractures of the hand. And when you release the contractures, there is every possibility of soft tissue deficit. And then you have to provide a supple soft tissue coverage so that the gliding of the tendons, the movements of the fingers is possible. A very simple example I want to give you. Now, if you look at my wrist, and if you look at your own wrists, and then I want to flex my wrist and extend the wrist, and the joint is absolutely fine. But if you were to imagine that there is some soft tissue contracture of the dorsal aspect of the skin here, and imagine that the pinching of the skin is a contracture, just by mere virtue of this contracture, my wrist won't go in a full range of movement. The moment we release the contracture, imagine that once the wrist is flexing, there is going to be a soft tissue deficit, and you need pliable soft tissue coverage on this aspect of the wrist joint so as to provide an optimum range of movement. So this is one of the most important aspects of the goals of the treatment whenever there is a soft tissue deficit or a contracture or scarring of the tissues. And then obviously maximum return of rapid return to work. When you leave a wound, forget about the hand, even when you have a compound tibia or a compound femur for that matter, and you allow the wound to heal by secondary intention, it just takes so long. So the wheels are turning in the opposite direction now. We used to always think about, the ladder of reconstruction. We'll come to that in a bit. So now with the ability to do soft tissue closures or soft tissue coverage, you can provide good coverage and early healing, and therefore allow the patient to return to work rapidly. And then obviously aesthetics. Who would want a poorly scarred or a badly scarred cicatrix that would look bad, and suffice it to say, it will also compromise the function. So the principles of reconstruction are listed here, and they are pretty universal, whether it is the hand, whether it is any other part of the body. So replace like tissue with like tissue. So as far as possible, especially if you have a wound on the palmar aspect of the hand, and this is a very special type of skin, it's a glabrous skin. So this is hairless skin. And therefore, you should avoid putting on a groin flap on this part of the skin, because you can imagine that it would look so ugly to have hair on the palmar aspect of the skin. Not only that, glabrous skin is very firmly attached because of the subcutaneous skeleton. So a blobby flap or a blobby kind of a unstable flap will jeopardize the grip function of the hand. If you're doing it on the dorsal aspect of the hand, and if the patient is pretty fair for that matter, you should try and get a flap that matches the skin color as far as possible. Now, these are ideal conditions, I recognize that, but this is just something that you should endeavor to do once you have the ability to reconstruct or perform soft tissue reconstruction in patients. And then you should also maximize form and function. And there are certain Vascon's laws. We will not belabor too much on that. And you should basically provide a supple skin or a supple soft tissue coverage, which is mobile, which is well vascularized, and maximizes your results to the best of the ability. And this is the reconstructive ladder that I was talking about just a little while ago. So the reconstructive ladder is something that we have all grown up with our residencies, and they used to talk about healing with secondary intention, then a primary closure. If the primary closure is not possible, then you should think of skin grafts or local flaps, and then think about distal pedicle flaps. And then if you have the training or the ability to do microvascular surgery, you could think about free flaps. But now, with more and more people um, having the ability and the infrastructure to perform microvascular or reconstructive surgery, the ladder has reversed now. So instead of climbing upwards, people are right here now. They perform free flaps, preferably so that the healing is optimized, it is expedited, and the patient can return to work early. And then if you really are not comfortable, not everyone can do free flaps. Even the most accomplished or the most well trained plastic and microvascular or hand surgeons, they are not very keen on doing free flaps simply because of the logistics, the long operative hours, and so on and so forth. But in hand, let me tell you, and you will be surprised to know that about 80% of the times you will be able to get away by doing distal pedicle flaps or local flaps. And then, of course, skin grafts wherever required. And if primary closure is possible, that is the best kind of scenario. But trust me that secondary intention healing should not even be in your vocabulary now. So to understand the flaps or to understand the possibility of providing soft tissue coverage, we should understand the vascular anatomy of the hand and the upper limb pretty well to know the vascular zones, to know the avascular zones, because if you're going to take a flap and if it is not perfused or if it is not well perfused, obviously you're going to risk losing that flap, and nothing looks bad than trying to close a wound with a flap and that fails. So you should know the anatomy very well. And just a very brief kind of revision of the anatomy. The ulnar artery, which is the post-axial vessel of the upper limb or the forearm, is the dominant artery. It is not the radial artery that is the dominant artery. And hence, we can very well harvest even a radial forearm flap based on the radial artery or the perforators that are arising from the radial artery. By perforators, I mean, so I'm just going to draw a quick diagram for you. So if this is the artery here, and then there are these perforator vessels that come from the artery, which are kind of perpendicular from the artery. And then they supply a part of the skin and the adipofascial tissue. So you can actually harvest a part or a flap of the adipofascial or a part of the skin based on these perforators, and thereby you can avoid sacrificing the main artery. So these are called as perforator flaps, but that is something which we will talk about in more detail as we progress. Let us stick to basics. So the ulnar artery kind of then traverses the wrist and enters the palm through the Guillon's canal, and then it kind of forms the superficial palmar arch. All right, so understand again, the ulnar artery is the dominant artery. And if you will realize, look at this picture very carefully, the schematic diagram. The radial artery, actually, the dominant part of the artery is going towards the anatomical snuff box and is not going into the palm. So here the artery plunges and goes into the anatomical snuff box, and it ends as the first dorsal metacarpal artery. Is that all clear? And then what you have, which enters the palm and joins this superficial palmar arch, is this very small twig, which is the superficial palmar branch of the radial artery, right? So again, if you really see this, schematic diagram carefully, the ulnar artery, which is the post-axial artery, is the dominant artery. It passes underneath the transverse palmar carpal ligament into the Guillon's canal along with the ulnar artery, and then kind of forms this arch, which gives off the common digital arteries, which branch into the collateral arteries. Understand that none of the arteries are actually coming from the radial artery. So therefore, the radial artery is not very, very important for survival of the hand or the fingers for that matter. It's the ulnar artery. And then as the arteries, they go along the fingers at every joint, especially the PIP joint and the DIP joint, they lie between two ligaments, the ligament of Grayson, which is the volar ligament, and Cleland's ligament, which is the other ligament, and they are robust ligaments which protect the artery along with the digital nerves. And then they go on, and around the fingertip at the base of the distal phalanx, they arborize to form the capillary network. And then you have the dorsal veins, which are the main draining veins of the hand. You have the cephalic vein, which is on the radial side, and the basilic vein, which is on the ulnar side, that go on to drain the fingers. So again, because we are talking about the fingertip, it is extremely important to understand the anatomy of the nail as well. The nail is a very important apparatus that provides stability to the fingertip. It allows for a counter force against which you can pinch. It is a very important aesthetic aspect of the hand, and it is a very important structure because whenever you have injuries, if you might provide a fantastic cover, you might do a flap, but if you neglect to address the nail, especially the nail matrix, and people have split nails, hook nails, or a rough nail, these people will be unhappy campers. So let us understand the anatomy of the fingertip. So this is the fingertip in sagittal section. You can see the flexor digitorum profundus attaching to the base of the distal phalanx.